everyone. This public hearing before the Health Systems Planning Unit of the Office of Health Strategy, identified by docket number 1832231CON, is being held on November 28th of 2018 to consider Yale-New Haven Hospital's application for the termination of outpatient primary care services. The hearing is being held pursuant to Connecticut General Statutes 19A, 639A, and will be conducted as a contested case in accordance with the provisions of Chapter 54 of the Connecticut General Statutes. My name is Michaela Mitchell. I have been designated by Victoria Veltri, the Executive Director of the Office of Health Strategy, to serve as the hearing officer in this matter. The staff members assigned to this case are Kayla Riggett and Shauna Walker. The hearing is being recorded by reporting services. In making its decision, the Health Systems Planning Unit will consider and make written findings concerning the principles and guidelines set forth in Section 19A, 639 of the Connecticut General Statutes. Specifically, the Health Systems Planning Unit will consider the following. 1, whether there is a clear public need for the proposed transaction. 2, whether the applicant has satisfactorily demonstrated how the proposal will impact the financial strength of the healthcare system in the state, or that the proposal is financially feasible for the applicant. 3, whether the applicant has satisfactorily demonstrated how the proposal will improve quality, accessibility, and cost effectiveness of healthcare delivery in the region. And 4, whether the applicant has satisfactorily demonstrated that the proposal will not negatively impact the diversity of healthcare providers and patient choice in the geographic region. Yale-New Haven Hospital has been designated as a party in this proceeding. At this time, I will ask staff to read into the record those documents already appearing in the table of record in this case.
Good afternoon. On behalf of the Office of Health Strategy, Health Systems Planning Unit, we would like to add Exhibits A through L to the table of the record.
Does the Health Systems Planning Unit have any additional exhibits that need to be added to the record?
We would like to add proposed Exhibit M, testimony of Ellen Andrews, to the table of the record as well.
So I will now go to the applicant. I'm going to ask if there are any objections to the exhibits.
No objections.
Okay. So this time the applicant will present its direct testimony. The Health Systems Planning Unit will thereafter ask questions of the applicant. Following those questions, we will hear from the public. At this time, I would like all of the individuals who are going to testify on behalf of the applicant to stand and raise your right hand to be sworn in.
Yes.
So for all of the witnesses that are here on behalf of the applicant, please remember to state your full name and also adopt any written testimony that you have submitted to the office prior to giving your testimony. And at this time, Yale-New Haven Hospital may proceed.
Yes, thank you very much, Hearing Officer Mitchell, and thank you to the members of the staff of the Office of Health Strategy who came down to New Haven today. Welcome. We're very happy that you're here. Just in the interest of time, I'm quickly going to introduce our witnesses today and then kick it off. We will start with Cynthia Sparer, who is Senior Vice President for Operations at Yale-New Haven Hospital, followed by Dr. Sue Lagarde, who is the CEO of Fairhaven Community Health Center, then Mr. Michael Taylor, who is the CEO of Cornell Scott Hill Health Center, and finally, Dr. Stephen Hewitt, who is the Director of Graduate Medical Education at Yale-New Haven Hospital, will wrap up. We do have other individuals here who were sworn in who have subject matter expertise if you do have questions, but given the limited time we have, this will be our presentation. So I would turn it over to Cynthia.
Thank you very much for the opportunity to talk about something that we have collectively been talking about and planning for several years now, and very excited to speak about it with you here today. And so again, thank you for the opportunity to do that. I do adopt my pre-filed testimony that's received. So the story, really the conversation began back in March of 2015 when Mr. Taylor, Dr. Lagarde, and I and others on our team had the opportunity to first sit down and really ponder the question of what we might be able to do together that we cannot do individually in order to address the substantial healthcare needs of the underserved community that we all serve. And so looking at the needs of adults, children, various population groups, were there things that we could take on together that we were not able or were not able to be doing individually? And that led to extensive discussions, frankly, trust building in what we could create together. And that's what we're here to talk about today and what we filed in our CON application. Our missions are very much in common. We have a long-standing commitment to the underserved needs of our community. We have been able to provide services over many, many years through the primary care clinics that we operate at Yale-New Haven Hospital at both of our campuses, York Street and St. Raphael's campuses. And similarly, that the hospital's partners in this dialogue have a long-standing, rich tradition and history of providing care to the community through their respective organizations. We took the time to look at potential models around the country that might help us understand better how we might accomplish such a goal. And we also took the time to really get some data that was important and helped inform our efforts. And that was to understand how people were currently receiving their care. And what became evident through the engagement of a third party is that there were literally thousands of residents of New Haven who were seeking care from both the hospital and the respective FQHCs, reflecting the duplication and other lack of coordination of receiving care in the city of New Haven and the surrounding communities. So what was born out of that was the idea of the creation of a consortium model that would respect the organizational entities as they are, not talking about any kind of mergers or anything, but taking each organization as it exists and creating what we think of as an umbrella organization, which came to be known as the New Haven Primary Care Consortium, which would have equal representation from the three entities to help guide our efforts in what we could put together. Ultimately, and I want to go through what the outline of the proposal contains, is the product of those conversations. Along the way in the planning process, we had physicians from our respective organizations, staff, and patients all part of that process. And so what we have come forward with and what we propose here today is the development of a single site for what are now 7 disparate sites of service that the hospital operates, contributing those into a single site, which we have designated as 150 Sargent Drive here in New Haven, where we would make an investment in being able to build a site that would support the services and contribute our primary care centers into the respective federally qualified health centers, specifically taking the adult medicine and women's services that we operate and having that assumed by Cornell Scott Health, and taking our pediatric programs, which operate over 3 sites at York Street, St. Raphael's, and in Hamden, and contributing those to Fairhaven Community Health Center. The investments that would need to be made at the site have been fully developed. We have plans that have been worked on by the respective teams, and we would look forward then to making what would be a $15.7 million investment for the capital investment by the hospital for those programs to operate at the 150 Sargent Drive site. An additional $4 million investment in the bringing together on a common electronic health record platform the hospital, the both federally qualified health centers, so that we truly would be able to have aggregated information to help us understand what are the services people are receiving, how we might identify needs and other things as we would be looking both at the short term and, importantly, at the long term for what those healthcare needs might be. And so having a common EHR platform allowing us to look at that aggregated information in a thoughtful way. We also have a critical element in what we are operating at Yale-New Haven Hospital, and that is that we are responsible for training the next generation of providers. And so an important part of what is embedded in our primary care operations is our teaching programs. And as part of this arrangement, we would be contributing those teaching programs and having the programs continue to operate under what we are putting into place through NHPCC, with, importantly, the faculty, the attendings at the hospital, the trainees, and the staff. We have staff who have been dedicated for years to the care of these patients. Those staff would be able to be then leased to the respective federally qualified health centers, so we don't lose the equity and the commitment and the experience of those staff, and in fact they can continue to work in an integrated model with the training programs, with the attending physician oversight, and Dr. Hewitt will talk a bit more about the training aspects in a moment. I think that what we are looking to do is really preserve and respect and retain the best of what we do today, and also learn from and gain the extensive experience that each of our partner institutions have in their own commitments to the care of the patients that they currently serve, and extending that to the care of the patients that are currently receiving their care through our primary care centers. So what we have accomplished to this point then is that we have, as I mentioned, convened the clinicians to develop a new model of care, one that is looking to really both, again, preserve what we have, but also address what we don't have. So a large example of that is the fact that we now have an opportunity to embed behavioral health services in each of the program elements. So for adult medicine, for women's care, and for children's care, to be able to have embedded behavioral health services at the site, as opposed to what patients experience today, which at our PCCs, which is needing to seek that care outside of the scope of what the PCCs are currently offering. So having that embedded at the site, we've again developed that model. We've designed the new site and established and approved at the hospital a capital budget for that investment. We have designed the installation plan for the common electronic health record and approved the budget for that. And we have developed community benefit grants to the respective FQHCs because one of the commitments going into this is that that they would not be harmed in any way or exposed in any way to anything that would destabilize their financial operations, and so the hospital would be taking on the responsibility for the costs, for example, of teaching, et cetera. And so through the community benefit grant mechanism, keeping the federally qualified health centers whole, if you will, and making that part of an annual grant that we would make to each organization. The other piece of this is timing. We are looking and hoping that we could see regulatory approval in early 19 so that we could meet the goal of having ourselves operational at the new site under the aegis of the respective FQHCs by the fall of 2019. So that would be our goal, and then our construction plans marry up with that time frame. When we look at it from the benefits point of view, I want to talk for just a moment about our patients. What we envision is that this will result in a streamlined access to enhanced care with a full scope of medical and behavioral services under one roof, coupled with the continuous relationship of the people that have cared for them, that families can receive care at a single location, that by co-locating the 3 clinics with the common electronic health record, we can avoid the duplication that we see in the systems we operate today. And that we will really, again, benefit from the expertise of both health centers in providing innovative, comprehensive care, which is part of their mission, to the patients that they're currently serving, and extending that to the patients that would be receiving their care at 150 Sergeant Drive. From the hospital's point of view, the benefits that we see are, number one, to invest more fully in primary care in an expanded model, and thereby avoiding unnecessary trips, both from the patient's point of view and the hospital's point of view, to the utilization of our emergency departments for reasons that are preventable. That we will be able to fulfill the major training needs of continue to fulfill the major training needs of our graduate medical education and undergraduate medical education programs. And Dr. Hewitt will talk more about that in a moment, but we really do believe that this is an opportunity to give trainees a chance to build core competencies in how you deliver efficient, effective, equitable care to the community, and in the hope that we will be able to entice some of those people to consider careers in this important arena. From a cost point of view, we do see opportunities by avoiding duplication of services, by having enhanced services at a single site, by coordinating care, again, the behavioral health example, but also with other specialty services in an improved and coordinated fashion, and by gaining operating efficiencies over the way we have currently operated our services through expanded hours of operation and throughput experiences that both health centers currently have in their operations. In terms of the costs that are incurred currently and then what we are underwriting at the hospital, we really see this as a reinvestment in the community benefit grants to the respective FQHCs, in the capital investments, in the sites that we are doing not only for the programs but also for related ancillary services, specifically radiology and laboratory services that are currently operated by the hospital at the 150 Sergeant Drive site that will be retained and enhanced through the investments that we plan to make in upgrades to them. And also in upgrades to the facility itself. It's a facility that needs some infrastructure upgrades, and we are committed to making them at the site as part of this project. And the other important aspect is we recognize that there are differences in the programs that we operate today for funding the care of patients who qualify for reduced rates under our existing hospital policies. We recognize that there are differences in those policies from the policies that the health centers currently operate. And so what we are working on today and will be working on in the months ahead is a hardship fund type mechanism to help ensure that patients are not disadvantaged financially by the differences in the policies that the hospital operates under and administers through the PCCs today with the policies of the health centers. And that is work that we have underway and still have work to do to come up with the exact mechanisms to accomplish that goal. But again, committed to not having the patients harmed in any way by the difference in our policies. Two other transition matters I just want to touch on before turning it over. There's been a considerable amount of concern expressed regarding transportation, so I'd like to address that. We do recognize that our patients have problems today in accessing care at the hospital's sites. Specifically, parking is something that has to be paid for, both at York Street and at the St. Raphael's campuses. What we learned through a survey of our patients is that fully 66% of our patients come to our campuses by car, and they face that barrier, and we often see our patients traveling blocks with strollers, with walkers, with other devices, to get to the site of care in order to avoid the cost of parking. At the new site, we will have free parking for our patients. There are approximately 250 spots. Currently, there are 279, but we want to enhance handicapped accessible parking spots at the site, so that will reduce the 279 number to an approximate number, and we're just fine-tuning it now, of 250 cars, so that our patients who do travel by car will have the benefit of free parking. We also know that the bus routes today are sometimes those routes and their frequency can be daunting, and we're committed to advocating for improvement in the bus routes that serve Long Wharf Drive and specifically this site. We also maintain a Yale-New Haven health system contract with Uber, and so one of the things we want to consider is being able to potentially utilize that contract for enhancing transport mechanisms for patients today. The other issue that has come up has to do with reproductive health services and those services that we offer today, and the question of, well, how patients will access reproductive services in the future. Just to remind everybody, we currently operate a family planning program at the hospital. We will continue to operate that program. We also refer patients to Planned Parenthood, and those referrals will continue to be offered in the future. So certainly want to assure that we are cognizant of and committed to maintaining the services that patients currently receive. So just to say that we are very excited about the opportunity that the creation of NHPCC affords us collectively, and very much look forward to the opportunity to address the needs of the underserved community, and doing it through the new mechanism that we are committed to maintaining through the NHPCC consortium operation. So thank you very much, and with that, let me turn it over to Dr. Lagarde.
Thank you, Cynthia, and good afternoon. My name is Dr. Sue Lagarde. I'm the CEO of Fairhaven Community Healthcare. Thank you for this opportunity, and for the record, I adopt my pre-filed testimony. So, as Cynthia has already alluded to, this is an endeavor that we've been involved in for now nearly 4 years. It's something we've been thinking about, talking about, rehashing in every which way. And some of the reasons behind Fairhaven's participation you can read in my testimony. But what I want to do with the very limited time I have today is answer a single question that I suspect all of you would like to know the answer to, and that is why. So why is Fairhaven Community Health Center committed to this project? As I mentioned, it's not something we've undertaken lightly. It's something that we've looked at and talked about and pondered upon for quite a while. And at the end of the day, it all boils down to mission. We are very much a mission-driven organization. In fact, our mission is to improve the health and social well-being of the communities and people we serve through high-quality, patient-centered care, and deliver it in a culturally sensitive manner. That is the lens through which Fairhaven does pretty much everything today, and it is the lens that we bring to this project. And given, again, the comprehensive services that we offer, from behavioral health, medical, dental, substance use disorder treatments, integration of the services, the high quality of the services, we could come to no other conclusion that if we can improve access to these resources, then it is something we not only should do, but it's something that we want to do. The second reason that is really imperative for us is the opportunity to bring together the 3 organizations in the greater New Haven area who care for by far the largest number of underserved population onto a single electronic medical platform. So I'm a physician. I provide care at Fairhaven. We have been on a shared EMR with Yale-New Haven Hospital for the past 5 years, and I can attest firsthand to the incredible power of that association. bring into that mix Cornell Scott Hill Health Center with its 30,000 patients. Now you're going to have over 70,000 patients on a single electronic medical platform. Opportunities for avoiding duplication of services, for knowing in real time admissions, discharges, transfer, and for obtaining in the aggregate very significant and meaningful population health analytic data is just, I would argue that it's probably unsurpassed in this country and really an opportunity for New Haven and for New Haven's residents. So that is something very important to us. And the third reason that I want to emphasize has to do with the future of something that is very important to all of us here at this table, and that is how do we provide the best possible care for the patients who we genuinely care so much about. And today, Fairhaven has a training program. We train residents and students from Quinnipiac University, from the Yale School of Nursing, from Yale. But in total, maybe in a year, we may cross paths with 20, 30 such trainees. This will provide the opportunity for literally hundreds of Yale trainees to be exposed to our world of high-quality, compassionate care for underserved populations. I think we can agree that Yale attracts some of the best and the brightest, and the ability to bring these trainees and to see the rewards, truly the professional rewards, the personal rewards, as well as the excitement of our world is an unparalleled opportunity. And I just want to stress that I don't think I have a Pollyanna attitude. I don't think we're going to transition 300 Yale residents from their trajectory of becoming active in academia or doing high-powered research. I'm sure that will continue. But I also am sure that we will change some minds and we will improve and increase the workforce for the future. And I think that's such a critically important aspect. So in summary, I just want to emphasize those three things. Why are we here? Why is Fairhaven at this table? Fairhaven is at this table because it is who we are. It is what we do. It is our mission. It is the opportunity to innovate in a way that is amazing and bringing all the underserved patients of the New Haven area, or the vast majority, onto a single electronic platform and all that that means. And it's our opportunity to really invest in the future. So I thank you very much for your time.
I know we have exceeded our time, but if I would just ask your indulgence so that Mr. Taylor and Dr. Hewitt could give very brief statements.
Yes, absolutely.
Good afternoon. My name is Michael Taylor. I am the CEO of the Cornell Scott Hill Health Center. I promise you I'll be brief. Thank you very much for the opportunity to testify today. And for the record, I do indeed adopt my pre-filed testimony. I'll make just a couple of comments about this collaboration. I had the very good fortune earlier in my career of assisting and formulating these types of collaborations in 3 locations across the country, one in Mississippi, one in San Francisco, and another in Pennsylvania. So when I came around the table with Dr. Lagarde and Cynthia, it was very clear to me what the benefits could be because I've seen it play out in other communities. It was beyond thrilling to have the opportunity to do so for a community and a population that I've come to adopt in my 8 years with the Cornell Scott Hill Health Center. And it really represents a resounding commitment of the organization to the well-being of the New Haven community. So I regard this collaboration as simply another evolutionary step in the bond that had existed between these 3 organizations for us 50 years. So we are at the next precipice, and I'm very grateful to participate in that. We have seen, we are not only an FQHC, but we are one who has long appreciated and embraced the importance of behavioral health as part of our organization. In fact, half of the Cornell Scott Hill Health Station is dedicated to the provision of behavioral health services, both mental health and substance use disorder treatment. So the opportunity to be able to offer that capacity and lend that expertise to another component of the New Haven community thrills us beyond belief and is really one step further in our moving towards achieving our mission of well-being for the community as a whole. I certainly reiterate Dr. Lagarde's message about the future, because what this will enable is collectively the opportunity for us and the resources for us to manage and bring greater health to the population that we collectively serve, and to do so in a manner that also avoids duplication and allows for greater continuity and coordination between the services offered by the three entities. So I wholeheartedly endorse this. I'm so glad we're finally here, and I hope you will agree that this really is a step into the future. Thank you.
Good afternoon. My name is Dr. Stephen Hewitt, and I am the Director of Graduate Medical Education at Yale-New Haven Hospital and the Associate Dean for Graduate Medical Education at Yale School of Medicine, and I adopt my pre-file testimony. And I'm here really to speak about our role as a training program and the engagement in this collaboration through the New Haven Primary Care Consortium, which I've had the privilege of being part of that conversation for the last several years. I started working in the primary care center at Yale-New Haven Hospital some 30 years ago when I started here in my residency training in internal medicine. I'm currently still a provider, now at the St. Rayfield campus of the Adult Primary Care Center. That's where I was this morning. And I have the opportunity to deliver direct patient care as well as to interact with trainees and all of our staff. Would you like me to hold while you figure that out?
Actually, why don't we just go, I'm so sorry to interrupt you. Let's go off the record just for a moment because I believe we don't know where that's coming from. So we'll go off the record just for a moment.
Sure.
Sorry, Dr. Hewitt.
No problem. We have to all get in the right bus line.
Yeah, we're off the record. We'll just wait till they conclude. before we get started and go back on the record, I just want to make sure that everyone who is speaking speaks directly into their microphone, because we did get some feedback that people in the back cannot hear. And so we'll go ahead and allow Dr. Hewitt to continue with his testimony.
So I'll resume from where I was.
That's perfect.
That works, okay. Yeah, so the context I was giving is that I have worked in the primary care center since I was a resident here some 30 years ago, and I continue to do so today. I wouldn't be sitting here as part of this collaboration if I didn't honestly believe that we have the opportunity to provide better care, better education, and a better work environment for all of our clinicians, and each of those goals are critically important for us to be successful at the end of the day. This is not something that we've come to lightly. We have 200 trainees who are going to be impacted by this opportunity to move into the 150 Sergeant Drive space. It will put our pediatric patients and their providers, our adult medicine and women's patients and providers in the same space. They will be cared for by the residents from Yale-New Haven Hospital and the faculty from Yale School of Medicine, which are the same providers who care for them today, and will be joined by the outstanding nursing and other staff that supports us in our current primary care centers. Working in collaboration with the physician leaders of our adult, pediatric, and women's primary care centers and our physician leadership colleagues at Cornell Scott Hill and Fairhaven Community Health Center, we've spent a great deal of time over the last 2 years really working through the nuts and bolts of how to blend an outstanding training, teaching clinical environment with an outstanding primary care ambulatory environment. We've in fact come up with 26 key guiding principles for how to do that, and that is everything from the first step when a patient calls to schedule an appointment to the follow-up and what we need to do to continue to engage with that patient when they leave our practice and connect with the resources in the community. From a training program perspective, we know from our own research and that of others that if trainees do not have the opportunity to work in highly functioning primary care environments as part of that experience, that is a detriment and a deterrent to their likelihood of choosing to work in those environments. The fact that we will be able to provide this experience to nearly all of our medicine, pediatric, and women's trainees is a huge plus. I firmly believe that this academic medical center, community health center partnership that we are building is one that really will become a national model for how to do this and how to do this the right way. So I'm very enthusiastic about the opportunity ahead. I'm very committed to the time, effort, and energy that it will require, and I am very confident in the creative ability of our trainees, of our faculty, of our staff, and I look forward to the active engagement in our patients for how to do this the right way so that it is patient and team-centered care, and I appreciate your time this afternoon.
All right. So, Attorney Wilcox, do you have anything additional that you'd like to offer?
Nothing further, thank you.
Okay, so we're going to go ahead and move on to the Health Systems Planning Unit questions.
Good afternoon. So I would like to first start off by asking questions that are related to accessibility. Will Yale-New Haven Hospital continue to provide the full range of currently available obstetric and family planning services not offered by the FQHCs at both the York Street campus and the proposed 150 Sergeant Drive site?
The hospital will continue, as I mentioned, to operate its family planning program, which includes the services that you're referencing, and so that program continues unchanged and will continue to be available to the patients who are cared for at 150 Sergeant Drive. That will be done by referral. The services will not be provided at 150 Sergeant Drive, but the program will continue to be maintained at our York Street campus and will be available to the patients who are served at 150 Sergeant Drive.
Okay, in the application itself, there's a table in Exhibit C, page 2, which lists the Sergeant Drive site as a proposed location for those services. So
the women's services will be moving. Our women's center that is currently at the York Street campus will move in its entirety, with the exception of services that are provided by our family planning program. So the full range of prenatal services and other women's health services that are provided by the Women's Center will move to the 150 Sergeant Drive site. The one exception are services that are currently under the aegis of our family planning program, and the family planning program will continue to operate at the York Street campus.
Okay, so they will not move. Okay. Will there be substantially the same number of available appointments for each of these services at that York Street location that are available currently?
So the full complement of providers that we have at the Women's Center will move with the program, and we have the medical director of that service here with us today, and she can amplify my comments, but it is the full complement of providers who will be moving with the program as with the other programs.
Okay, thank you. Now, will these services, just to confirm, will these services be offered to the same patient population as well as the same payer population?
Sorry, could you clarify when you say these services? Which services are you specifically referring to?
The ones that will be maintained by Yale-New Haven Hospital.
I'm still a bit unclear on the question. If you could just repeat it again.
So the services that will remain with Yale-New Haven Hospital, will these same services be maintained for the same patient population as well as the same payer population? So will the same payer relationships be maintained?
Yes, we will not. There is no discrimination based on the payer class of patients that we serve through the program, and that will continue.
Thank you. So in your pre-filed testimony, you discussed that a transportation subcommittee would identify initiatives to alleviate any accessibility concerns. And there was some discussion in your testimony here today in regards to Uber contracts and discussion with public transportation routes. So can you share any updates in terms of what Yale-New Haven Hospital, if they will have any plans to alleviate any of these concerns?
Let me first talk about the hospital and then talk about our consortium, because a lot of this work is being done through the mechanism of our steering committee for the creation of the consortium. Specifically, we chose the site, 150 Sergeant Drive. One of the assets of the site is the fact that we have the surface parking area that we do, currently serving 276 cars. It's an active ambulatory site that houses a very busy primary care practice, project access, other services, along with radiology laboratory services that are used and patients are referred to. So we understand and have the benefit of an existing operation there that includes a multitude of ambulatory services. The fact that we have the surface parking we viewed from the beginning as one of the key assets of the site in order to repurpose it to support the New Haven Primary Care Consortium. So we know that, we have that. What was important is to understand from our patients, and that's why we surveyed our patients, to understand how they travel to the various sites of service that we operate. And one of the important learnings from that was that there was, as I mentioned, a 66% response that patients use cars to get to the site. So we then knew that we had a current practice that married up with the asset that we have at the site. As to the rest, because obviously 66% is not 100%, there's another third of patients who use other means, including buses and other mechanisms to get there. And so those are the things that we are continuing to work as a steering group to best understand what we need to make available in addition to the asset of the parking. And that will include, as I mentioned before, things that we still need to work on, and that is the advocacy for enhanced bus access, as well as the opportunity that we have, and we do have experience for other patients of the hospital today where we are using supplementary transportation mechanisms, which is what led to, for example, the contract that we currently have with Uber. So whether there is the use of Uber, which we use for other patient populations, other services, whether it's through some type of shuttle services, those are things that we still have in front of us to work through, and we will do that, continue to do that work through our steering committee.
The Uber contract, is that absorbed by the consortium, or who?
Again, we have not worked through, that is one opportunity, so we have not per se developed an agreement around that. We're simply listing out right now as some of the assets that we have and how we might purpose them on behalf of the consortium.
Okay, when will the consortium have a plan in place?
Well, given that we're about 10 months away from operation, it would be sometime over the coming months that we're working through these details. But we know going into it that we have this as one mechanism that's a potential.
And do you anticipate that you'll have some type of formalized plan?
We absolutely will need to have a formalized plan before we would become operational, the goal being next September.
Okay, thank you.
Thank you. Now, what is the protocol for accommodating patients with travel-related delays in arriving for scheduled appointments? Seeing how some clients or some patients may have transportation issues getting there if they're taking public transportation or walking.
So if I understand your question correctly, that really becomes an operational issue, and I would really defer to my colleagues to the left and right of me to take on that question.
I'm happy to take that on because it's an issue that we encounter on a daily basis. As we have a number of patients in our core sites who have transportation issues and who therefore really don't control their mode of transportation and who therefore might be late for appointments. And what we have is a grace period that allows people some leeway for circumstances that are simply beyond their control.
And I can second that. The situation is the same. There is a certain amount of time that is allotted. We do encourage patients to come a little bit early to help make up for that. But it's not a hard and fast rule in terms of people who have access issues. Obviously, there comes a point where it's not possible to see somebody if they are truly very late, but then the goal is to accommodate them in any way possible.
Okay, is there an estimate about how long this grace period is, the time?
I believe ours is 15 minutes, but I can't even recall a time when we ever or would ever turn a patient away under those circumstances. It just doesn't happen.
Yeah, comparable sort of time periods, yeah.
Okay. Thank you. Now, are you able to provide some background on the primary collaboration agreement, just for the sake of the public and for the record?
We conceived the construct of the consortium as an equal three-way representation, and we'll have 2 seats from each of the 3 entities serving on the board of this consortium. Again, just to underscore, the consortium is not a provider of and by itself. It is really a reflection of the 3 provider entities that are coming together to form the consortium. So the organizational integrity of each is maintained as it is, and then overlaying that, we have this table that we will form. It is currently a steering committee. It will convert into an ongoing entity that we will operate, which will continue to bring the 3 of us together to oversee the activities of the consortium, deal with the kinds of things that Dr. Lagarde talked about a moment ago about the data, the opportunities where we may be able to work collaboratively on initiatives that get identified as the care is being delivered. So that will be the ongoing work of the consortium that we create.
Thank you.
I would just add one other thing, because it's been touched on, and Dr. Hewitt touched on this also, is that we have been at this now for several years, and so the active planning process will as opposed to having to launch something that is new, will really be a continuation of the work that we've been doing on the planning side, then moving it to operational.
Thank you. Now, if all three parties of the consortium mutually decide to terminate the primary care collaboration agreement, how will continuity of care be provided to patients?
I think the first most important thing to mention is that we created the agreements as a 5-year agreement. So everyone felt strongly that there needed to be a deep time commitment to the creation of this. To have done something like this and said that there was a 1-year annual renewable or whatever would not really reflect the intent, the purpose, and again, the time that we spent in the creation. So the commitments that we've made to each other is around a 5-year time frame. I think what that does is speak again to the long-term view that we are taking about what this is that we're creating, and then give us the opportunity to learn, as you do with any new venture, what might be improved, what might be enhanced, what needs to be redeveloped. And again, I'd look to Sue and Mike to add to that answer.
So if, in the unlikely event that the three entities decided to terminate, I mean, as this moves forward, these will be Fairhaven patients. The patients that we assume the care of, they are our patients. Our organization is not going away, and we will continue to care for those patients. Now, that might, either we can absorb some of those patients in our current sites, it might require new sites, that obviously would have to be determined at the time. In the end, we always say it's patient choice. Patients are going to decide where they want to go, but certainly if they wanted to stay with the health center, we would make certain that that was easily an easy possibility to achieve.
I would echo Dr. Lagarde's comments. Once you're a patient of the Cornell Scott Bell Health Center, we don't let you go. We couldn't conceive of abandoning our patients under any circumstances. But I would say on the other side of that you don't enter a relationship like this one lightly. And it's required an extraordinary amount of work on the part of all three organizations. And you don't do that, you don't make that commitment with a short-term view in mind. So we don't think that's simply going to be a reality.
I also would like to add to that, again, I'm here representing our training programs. We have 200 trainees who will be working in this site. It is a requirement of their accreditation that this opportunity to care for patients in a primary care environment exists. It is the responsibility of Yale-New Haven Hospital and Yale School of Medicine to assure that that is the case. We are going nowhere, so our commitment is ongoing.
And I would just add to that the patients we're talking about, it's really illustrated by the data we referred to, where we represent 95% of the care to the underserved in Greater New Haven, that we will always need to be able to assure that there is access to care in this community. And those patients that will be patients of the two respective organizations are the same patients that use our emergency department, get admitted to our hospital, need the other services and programs that we operate. So that will continue, and if in the very unlikely event at some distant point in the future there is a need to step into a gap that has been created, we will need to do that as well, because we do need to have continuous care in this community.
Thank you. Can you discuss the coordinated scheduling protocols?
Coordinated scheduling protocols.
This was mentioned in the pre-file testimony, Exhibit K, that there will be coordinated scheduling protocols. I believe it's page 31 of the pre-file.
Who's pre-file? Sorry, who's pre-file testimony?
1 second. Dr. Hewitt?
I proactively asked for the microphone. So that's one of those 26 guiding principles that I briefly mentioned before, and the coordination is both to assure continuity for patients, continuity for residents, continuity for our faculty, so that we can really work in a team-based model, but also have the flexibility to take into account the sophistication that trainees develop as they go from their first to their second to their third year of training.
Okay. Is there any idea of how soon a patient will be seen from initial contact, once they contact either of the FQHCs?
What's your current time to first appointment?
So currently, we see people when they call us at 9 a.m. and we'll accommodate them by 11. So access is not an issue. We would anticipate that our practice in that regard will not change. So we will create a way of accommodating same-day visits. It's part of how we function.
And I'll just add to that, as I tell my staff, we need to think of this as another site for Fairhaven Community Health Center. So our policies, how we care for people, what we do today will be the same across the entire organization. So we see people, depending upon their needs promptly, depending upon their requests. Sometimes they'll request a particular provider, and that will be no different at 150 Sergeant Drive.
So can you clarify whether this will apply to new patients in addition to your existing patient base?
Yes.
Okay.
Yeah.
Thank you. I would say yes also, and just a further clarification, at our main care site, which is maybe a half mile from Sergeant Drive, we offer a same-day convenient care clinic. It's a walk-in. It's busy all the time for reasons that, things happen and people need to access their provider in a timely manner. It's part of serving the population that we do. We don't anticipate that's going to be terribly different with the population at Sergeant Drive, so we'll likely adopt a similar practice there.
So it's unlikely that patients will be waitlisted?
It's certain that patients will not
We don't waitlist patients.
We do not waitlist.
Thank you. Now, in the event that a patient requires services not available at the location, what is the protocol for facilitating provision of the service in a timely manner?
I guess I'm not 100% certain. If somebody can't get an appointment,
No, for services that are not available.
That are not offered.
I see. So for instance, let's take dental, for example. We operate a full-service dental practice down on Grand Avenue. They could be referred there. Cornell Scott offers a similar service. They could be referred there. The hospital offers similar services. So, there are ample opportunities, and we could go specialty by specialty.
As an example, our dental operations for the hospital are at 1 Long Wharf, which is just down the road from 150 Sergeant Drive. So there's a very short distance between where services that we provide at 150 Sergeant Drive and the hospital's outpatient dental services, as an example.
Will same-day referrals be available to minimize repeat travel?
So the referral, I think again, you have to clarify referral to what. So for instance, one of the things that's been emphasized and that's very exciting about this endeavor is that we're going to have embedded behavioral health right on site. So when the patient comes for, say, their well child visit and parents identify a behavioral health need, there will be somebody right there and able to address that, or at least begin the process of addressing that right in the moment. Now, if that child needed specialty cardiology services, let's say, then that probably would not be there on the same day, but certainly a referral would be made by our team, and they would, ensure that they got seen in a timely manner.
I would add too that it really does depend upon the type of referral that's needed. So, as an example, the Cornell Scott Health Center also offers a broad array of specialty and subspecialty services, including basic or core primary medical services, and also also a broad array of behavioral health services. We could walk there from here, and we're also not very far from Sergeant Drive, so access I don't anticipate will be an issue for the patients. In fact, quite honestly, some of these patients may gain access to care because we're so proximate to Sergeant Drive.
I think the one other point I would add, just for clarification, is the hospital operates today and continues to operate specialty clinics, and so those clinics will continue to be available to the patients that will be served at 150 Sergeant Drive.
Will there be formal referral agreements with other providers that provide services not available from the FQHCs?
We have those relationships today, so that would be unchanged.
Thank you. For my next set of questions, we'll discuss they relate to the cost of care to the consumer as well as the healthcare system. So earlier you mentioned the availability of a hardship fund mechanism. Now, can you confirm if this would be available to patients that are not able to pay any out-of-pocket costs or those that are not eligible for any hardship waivers through the FQHCs?
So I'd like to underscore what I said earlier. This hardship mechanism that I referred to is something that we have committed to work collaboratively to develop. It does not exist because, again, what we're starting from is that these will be the operations of the two respective organizations. They have their own policies, and what we have to dive into is the detail on what those policies cover and what the gap or differential may be between what those policies allow for and what the patients who are currently being served in our primary care centers receive as a benefit today. And then it is that gap that we would work on to develop a mechanism to assure that we've not disadvantaged the patients in terms of out-of-pocket.
And I think it's, perhaps this is a good point to maybe put a little clarity on our what we call our sliding fee scales. They're a bit complicated, so bear with me. But these are all policies that are in fact required by HRSA, who is our primary federal regulator. So, for instance, today, Fairhaven Community Health Center has nearly 25% of its nearly 19,000 patients are uninsured. When those patients come in, they are asked for certain bits of information to determine where on the sliding fee scale they belong. And those information is their household size and their household income. I can tell you that of our uninsured of our entire population, more than 70% of our patients fall below the federal poverty level. For those patients, they would be charged, and again, this is a HRSA regulation, they would be charged what is called a nominal fee, which at Fairhaven is $25. A patient is never, and I'll repeat, never turned away because they say they don't have $25. They can say they have $5, they can say they have 5 cents, they can say they have nothing. They are seen. Again, per HRSA regulations, they do receive a bill. It is our policy that they receive one bill. If they don't get paid, if we don't get paid within a 6-month period, that is written off to bad debt. And that happens time and time again. So it is in no way punitive, coercive. It is following the rules that we are asked to follow, that we are required to follow in a very caring, compassionate, understanding fashion. Occasionally, patients will also come and say, we just know we can never pay that. And then we have a full policy, hardship policy, write-off policy, where they don't even get the bill. It's just written off. So it's a complicated system, and then that's for those patients below federal poverty level. Then we have to have several gradations based on percentage of all the way up to 200 of federal poverty level. And again, then HRSA requires us to charge if somebody is beyond the 200% of federal poverty level. But again, everything that I just told you applies. No one is ever turned away. No one is ever coerced. We don't have any relationship with any collection agencies. We don't even send them 2 bills. We send them 1.
It plays out pretty much the same way at the Cornell Scott Health Center. The metrics are different, but the process is the same. We also have and put forth an extraordinary amount of effort and have a whole team of people who work with patients on a daily basis to get them qualified for public health insurance, to determine where some applicability might be in that regard. But again, metrics are different. Our funding comes from the same place as Fairhaven's. The rules are the same, so we do it the same way.
Thank you. So does Yale-New Haven Hospital currently have contracts with all the commercial players in the area?
I hesitate to respond to all, since there are many, large and small, and we do have a finance representative here in the room from the hospital who might want to help with answering that question. This is Mr. Brett Perrone.
Before you start testifying, just make sure you state your name and what your title is.
Okay. My name is Brett Perrone. I'm the Executive Director for Financial Planning at Yale-New Haven Health System. So to answer the question a little bit more directly, all of the major insurance providers in the region we have contractual relationships with.
Thank you. Now, will the FQHCs continue the same payer relationships?
Like Yale-New Haven, well, directly, yes.
Yes.
But like Yale-New Haven Health System, we too probably have provider agreements with most of the major commercial payers. We don't anticipate this collaboration is a reason to, and thus we will not likely change that.
Exactly the same. It's impossible to have a relationship with all of them. I don't know if you've ever looked at it. There are literally dozens and dozens. But certainly all of the major, without question, and that will not change.
And in each of the major commercial,
Make sure you speak into the mic.
each of the major commercial payers might have literally hundreds of plans under their name. So Blue Cross is not Blue Cross. It's literally hundreds, if not thousands, of different plans that speak to different populations.
Okay. Would the new negotiated rates be comparable to those received at the PCCs, at the primary care centers?
I'm really, you're going to need to clarify that question.
They become
I
patients.
don't know what new negotiated rate you're talking about.
In regards to the payer contracts?
Oh, so we will operate under a single TIN, right? We operate under one tax ID. That tax ID will be extended to 150, to our patients at 150, to our practice at 150 Sergeant Drive.
That's reasonable too.
Okay, thank you.
Okay.
Now, throughout the application, it is stated that the proposal will result in a cost savings to the state Medicaid program. Can you please explain that, just for the public and for the record?
So I think the primary document and analysis we've referenced throughout I apologize. That we've referenced throughout our submitted documentation is the work done by, I believe it's Dr. Zavosky, on behalf of the DSS. So the specifics of that analysis are something that I think we're not aware of, as we didn't participate in the analysis. I think the results were positive from the perspective of the state and in the hospital around cost savings, and that's our basis around our savings argument. I mean, I would add to that additionally, there's all the conversations that we've had around the continuity of care, the single electronic health record, I think will have effects financially for the state and the hospital and the patient throughout their course of care. The more effective we are with primary care, the more reduction we'll have in acute admissions or seeing patients in the ED, things like that.
Thank you. Now, for my next set of questions, we're going to address the financial feasibility. Can we just explain the terms of the community benefit agreement as well as the initial startup grant?
The community benefit agreement is the mechanism that we are using to look at costs, for example, the cost of teaching. There is absolutely a difference between an experienced provider and one who was in training. So there is a cost associated. The number of patients that a trainee can see is not the same as somebody who is an experienced physician or advanced practice provider, et cetera. So that differential is what we refer to as a cost of teaching. In order to assure that each of the organizations is not harmed financially by assuming the responsibility of the care of the patients, a cost like that is going to continue to be borne by the hospital and will come back to the two organizations in the form of the community benefit grant. A second example is that we are going to be leasing staff to the two organizations. The cost of their compensation and benefits we know is higher than either of the organizations, so the differential in that cost will continue to be borne by the hospital. When we took a preliminary, and this will have to be adjusted annually because their costs escalate, but when we took the initial pass in great detail, and there was a lot of excellent work done by both Cornell Scott and by Fairhaven and the financial team at the hospital, our calculations were that there would be a combined $8.9 million in community grant dollars that would need to be paid in the first year of operation. So that will need to be reviewed each year, but that is a good number using FY17 data for us to be able to project what the size of those grants would be. And that's how we arrived at that $8.9 million number that I referenced earlier.
Thank you. Now, there was mention of the 2-year cap under the community benefit agreement. Now, is this calculated annually following the initial 5-year period?
You'll have to say a little bit more about 2-year.
There's mention of a rolling 2-year cap.
So I think part of the agreement is that we have an annual review process where we could potentially adjust the cap. And I think setting the cap at a 2-year period is to create an estimate of the financial burden to be taken on by the new entity. So like Cynthia said, we did all this work on FY17, which came up with an estimate of $8.9 million. Annually, we'll go through what actually happened, and we'll adjust that cap for the 2-year period.
So this is upon execution of the proposal? Or is this following the first 5 years?
So I think some of the specifics of how we're going to do it we'll work through in the next 10 months. Okay. But I think the overall intent of the grant is to ensure that the FQHCs don't get a negative financial impact because of the overall agreement. So what we end up doing, the details, will be tailored and designed around that.
So this is in addition to the initial startup grant that's received?
I'm unclear when you're referring to a startup grant.
Capital investment.
The pre-transition.
The pre-transition, yes, sorry. Right, so that is, there are one-time costs leading up to day one, and that is in addition to those one-time costs.
Okay, so they will receive both?
Yes.
Okay, thank you. So for my final question, or set of questions, this is in regards to quality of care. The pre-filed testimony frequently mentions that the proposal will focus on best practices and innovative care protocols aimed at improving the health status of the underserved and long-term outcomes. Can you please please elaborate and provide specific examples?
So let me start, and that's a loaded question. So as I said before, this will be another site for Fairhaven Community Health Center, and so all of our current quality initiatives and quality programs will apply equally there, fueled in part by a lot of very positive discussion that has ensued amongst providers and staff over the past several years as to what we conceive to be the ideal model of care. Speaking for Fairhaven, I think it's fairly well known that we do provide, I'll give a chance to brag a little bit about the quality of care we provide. We are one of only 2 FQHCs in the state that are dually accredited as patient-centered medical homes by both NCQA and Joint Commission.
I am so sorry to interrupt you. I just want to make sure that when we're speaking, we make sure that we don't use acronyms. Just the public may not know everything, so it's fine. So if you use an acronym, just let us know what it means, but just try if you can remember not to.
I'll try. Sorry. So again, duly accredited as a patient-centered medical home by 2 of the major accrediting bodies, which is the Joint Commission and NCQA, National Committee of Quality. I'm not even sure what it stands for. We received from HRSA for 3 consecutive years what they call their HRSA is the Health Resources Services Administration. It is a division of the Department of Health and Human Services, and it is our regulatory body. And we received from them for the past 3 years their Health Quality Leader Award, which is given to fewer than 30% of health centers in the country, and there are roughly 1,400 health centers in the country. We also received an award for what they call the Health Disparities Reducer. And just very recently, literally several weeks ago, the PCMH Plus program of the Department of Social Patient-Centered Medical Home Plus, that's its name, it's called PCMH Plus program, sorry, of the Department of Social Services. The quality metrics were announced for its first year of operation for calendar year 2017, and out of 9 participating entities, Fairhaven was number 1. So I have no doubt that with our committed staff, quality is paramount. It is number 1 priority for us. It is up there with everything else. And that will continue because this is basically an extension of what we do today.
Likewise, the Cornell Scott Hill Health Center continues and has always been committed to quality, has been recognized by a number of national bodies for really being truly innovative with respect to integrated behavioral and medical care. We are the poster child for integration. We are very proud of that. It has enabled us to care for very clinically complex and complicated patient populations. So it's no secret in Greater New Haven that when you're really sick, you come to the Cornell Scott Hill Health Center because the fact of the matter is that our breadth and depth of services enable us to care for the most complicated patients. And so that will continue, and we look forward to bringing that expertise to a broader population. Did you want to comment?
I feel like we're all beating the same drum here. I'll give you a specific example. So one of the things we do not have at the primary care centers right now is embedded behavioral health. What we will have when we move into the new site at 150 Sargent Drive is for every 6 exam rooms, one of those 6 exam rooms is a behavioral health specialist. So if I have a patient who I'm seeing, who I need to transition care or get advice or assistance from a behavioral health specialist, I can do that right then and right there. And evaluating the impact of that, not just on the behavioral health condition that the patient has, but on their other medical comorbidities that we as primary care doctors are trying to address, is something that we can do in the new model that we cannot do in the current.
And by the way, that's a practice model that we have adopted and been utilizing for years.
So I think that concludes our questions. We're all set with our questions.
Okay, so we are going to go ahead and move on to our public portion. Thank you so much for just being patient and waiting. And before I do that, I just want to check with Attorney Wilcox. Anything else additional?
For the record, no. Thank you.
Okay. All right, so each person who wishes to speak should have written their name on the sign-up sheet that was provided in the front. We will be calling the names of those who have signed up to speak in the order in which they've signed up. For those of you who do not wish to speak today, just keep in mind that you can submit your written comments in writing, and anyone who wants to do that should do it before, or actually on or before December 5th of 2018. The email and the mailing address have been provided to you on the informational sheet once you came in. If you didn't get one, just make sure that you get one before you leave. Are there any, just very quickly, are there any elected officials? Okay, so we're now ready to go ahead and hear statements from the public.
Using this microphone?
So there is a microphone to my right. There's a staff member from the Health Systems Planning Unit. Her name is Leslie Greer, and she's holding the microphone up. So once you come up, you're going to go to your left. Ms. Greer is standing up, and just retrieve the microphone at that time. Once you receive the microphone, make sure that you come to the center of the building right behind the applicant and make your statement.
Okay, with the following persons come up: Ellen Andrews, Vincent Diaz, Mary Ellen Flaherty,
Hewitt, and Marjorie Eckler.
Can I ask that your indulgence, Marge Eichler?
Make sure you speak into the microphone.
I'm Ellen Andrews, and I'm first on the list, but I would be happy to trade my space with Marge Eichler because she has to leave and go to a very important meeting. She has children that she has to take care of. Is that all right?
Yes.
Okay.
Hi, good afternoon. I'm Marjorie Eichler. I'm an RN MPH, founder and president of There's No Place Like Home, Inc., one of the former co-chairs of the Medicaid Managed Care Council, a former clinical instructor at the Yale School of Nursing. I'm here today because I speak to you as a consumer and a patient. I attend primary care services at Yale. I have 3 adult children with disabilities who also receive their care at the primary care center. We are all on Medicare and Husky, so we are the poor folks. When I had Blue Cross, I had my choice of physicians and places to get care. Once I became a Husky and Medicare client, my access to health care diminished. I had basically the choices of Hill Health Center, Fairhaven Clinic, and primary care. And I'm sorry to tell you that Hill Health Center did not work out well for us. Long waits in the waiting room for hours, my phone calls not returned, much difficulty in getting refills on standard medications, which I'd taken for 20 years. I switched to primary care at Yale-New Haven. I've had the same physician for a couple of years. Continuity of care is perfect. Through my chart, I can access messages back and forth on a daily basis if necessary, as well as I can reach her by phone. At Hill Health Center, the turnover of physicians was terrible, and I never knew who I was going to see when I went in. I think at the head of things, it's good, but when you're the patient at the bottom, it's not always so good. And when we don't have a lot of options, I am very concerned if we put everything together and my options are nowhere now. Primary care is wonderful. I wish that it would stay just like it is. Thanks.
Ma'am, before you speak, I just want to make an announcement to the applicant. Just I'm sure you're listening very intently to what the public is saying. I just want you to be prepared because we might ask you to speak to some of the concerns that we're hearing prior to the end of the hearing. So.
Hi, my name is Nitsa. So hi, everybody. So I'm going to read so that I can keep to my 3 minutes. My name is Nitsa Diaz. I am the chair of the board for Fairhaven Community Health Center. I have been a member of the board for over 15 years and the chair for over 5 years. I've also been a patient, I can't really read this without glasses, of the health center for over 6 years. The Fairhaven Board of Directors is currently composed of 12 individuals, the majority of whom are patients of the health center as it is required by HRSA. In keeping with HRSA regulations, we meet monthly to help guide the mission and oversee the fiscal health of the center. I am here today representing the full board of directors to let everyone know that the Fairhaven board unanimously supports the proposal before you today. I am also here to let you know that this is a decision that we did not take lightly. For several years, we have been kept abreast of discussions that have taken place among leadership from the 3 organizations, Yale-New Haven Hospital, Cornell Scott Hills Health Center, and of course, Fairhaven. Many hours of discussions among our board members have taken place. Many questions have been asked, and yes, we have had many heated arguments in our boardrooms. However, in the end, every one of our 12 members of the board voted to endorse this initiative. Why did we do that? Simply because we believe in collaboration, and we also know that this aligns to our mission and vision. While we realize that our tendency as a Fairhaven clinic was to stay isolated in our little Fairhaven section, we know that in order for people to have access to care, we need to provide care to anybody who needs it, and this collaboration is going to do that. All members of our board of directors are extremely proud of our health center. We have over 220 staff, many of whom live in the community, and I say that. Oh, I'm sorry, I'm trying not to.
Sorry about that. Just a little, move the microphone away.
So
from
many
you.
of our 220 staff, many of them, I'm very proud to say, live in the New Haven community. We really are about that as well. Strive every day to provide the highest quality care to our nearly 19,000 patients. We are proud of our many achievements. We are recognized both nationally and locally for our high quality outcomes. For the past 3 years, we have been recognized by HRSA as a health quality leader, a distinction bestowed on fewer than 30% of the nearly 1,400 health centers nationwide. In the past year, we received HRSA's Health Disparity Reducers Award, a citation received by only 5 of Connecticut's 16 federally health qualified health centers. We were one of the first FQHC, which is a federally qualified health center, in the state to receive the PCMH, or Patient-Centered Medical Home Accreditation, and we are one of the 2 health centers in the state to be dually accredited by both commissions. Just a few weeks ago, we were recognized by Connecticut Department of Social Services to be in the top tier of 9 entities participating in the PCMH Plus, and I'm sorry, I just gave you the whole, what it stood for. A shared savings program run by DSS based on our clinical quality matrix. Given our strong clinical programs, we are eager to make our services available to as many patients as possible, and we see collaboration as a good way to ensure that many more patients will have access to our high quality of care. This true collaboration is what can help us with continue to narrowing the health disparities that exist in the city of New Haven. Last but not least, we also recognize that to walk away from this option would not be a good business decision. The economies of scale can and will be realized through this collaboration are significant. In summary, I urge the committee to grant a CON to Yale-New Haven Hospital. By doing so, you will be contributing to an innovative program that will provide true collaborative and equitable access to high-quality, cost-effective care to the majority of low-income patients in the New Haven area. Fairhaven Community Health Center is committing to ensuring that all patients who need access to high-quality care receive it regardless of their race, ethnicity, culture, language, religion, socioeconomic, and disability. And thank you for your time.
Great. I'm not that coordinated. Thank you. Good afternoon to the members of the Office of Health Strategy. My name is Dr. Mary Ellen Flaherty Hewitt, and I'm delighted to speak with you today about this important project. Thank you for this opportunity to share with you my thoughts on this innovative collaboration and the benefits that I believe it will bring to my patients. I am the Medical Director of Yale Pediatric Primary Care and Associate Professor of Clinical Pediatrics at the Yale School of Medicine. I am honored to be part of an amazing team of physicians, nurses, advanced practice providers, residents, and students whose primary focus is to care for over 13,000 children in the New Haven area. I have been caring for children and families in this community for over 15 years, and I have the best job in the world. As a pediatrician, addressing the medical concerns of children is a crucial part of the work that I do, but there is so much more. I help new parents as they discover the amazing developmental capabilities of their infants and toddlers, and I am there to help navigate resources when perhaps things are not going as they expected. I celebrate their time as Student of the Week, Athlete of the Month, and I also help children and their families navigate the stresses of food insecurity, inadequate housing, bullying, and see more and more how our children are affected by this stress. A 2009 report on the National Research Council and Institute of Medicine stated that 1 in 5 children in the United States experience a mental health disorder in a given year. As a general pediatrician, I see 20 patients a day. Therefore, on a daily basis, I am seeing children who present with ADHD, depression, anxiety, autism, oppositional defiant disorder, and their sequelae. My training in pediatrics 20 years ago did not prepare me well for the complexity of mental health issues affecting our youth today. I have attended many conferences and workshops to help me better care for my patients, but I still feel we can do better. Mental health issues are becoming more and more prevalent in primary care offices across the country, and I am most excited about the possibility of embedded behavioral health that will be incorporated in the New Haven Primary Care Consortium, and how it will greatly enhance the care that we can provide for the children of our community. There are well-recognized gaps in the availability of behavioral health care for children, and there is a developing consensus that the primary care pediatrician must be at the forefront of providing this care in their office. With a behavioral health specialist embedded in our team of providers, we will be better equipped to identify children at risk for mental health issues and increase the proportion of children who are diagnosed with depression, anxiety, other common behavioral health issues, and get them into treatment sooner. This opportunity for embedded behavioral health will most certainly improve the overall care we can provide for their children and their families, but it also allows us as educators to significantly enhance the training of our future physicians, nurses, and advanced practice providers. Having our residents and students working side by side with behavioral health specialists will help train our next generation of healthcare providers to become comfortable and confident in providing this very important service in the primary care setting. We have worked in partnership with the Fairhaven Community Health Center for many years, and the New Haven Primary Care Consortium gives us an opportunity to deepen that partnership. Bringing our patients together in one location will allow us to strengthen our team-based models of care, allow our patients to continue their current relationships with their physicians and advanced practice providers. The ability to have ancillary services on site will help our patients save valuable time and allow our providers to get important results in a timely fashion to improve the care that we provide. On-site free parking will enable our encounters with our patients to be more meaningful by removing the stress of having to watch the meter. Thank you for giving this application the attention it deserves. I'm very proud of this effort, and I look forward to the benefits it will provide for the children of New Haven.
Hi, I'm Ellen Andrews. I want to thank you for the opportunity to share the Connecticut Health Policy Project's deep concerns about this Certificate of Need application. The Connecticut Health Policy Project has worked for almost 20 years to expand access to high-quality, affordable health care for every state resident. We're concerned if this application is approved, access to care for low-income New Haven area residents will be harmed and Medicaid costs to the state will escalate. In speaking with New Haven area Medicaid members and community groups, and I have to say I also teach at Southern, I teach health policy to public health students, and many of them actually will be affected by this and didn't know anything about it. We found very few people in the community who are aware of this proposal. Most voice very serious concerns when they hear the details. People are particularly concerned that the proposal will drive more patients to already crowded community health center sites. We've heard from providers in the current primary care clinics at Yale and beyond with grave concerns that the proposal won't meet the needs of their fragile patients. Community groups we've met with on the issue are deeply concerned about the transportation barriers to care and are skeptical, I guess is the word, about the answers to the question. Unfortunately, neither the providers nor the community groups are comfortable sharing their concerns publicly. Beyond the New Haven area, the Connecticut Health Policy Project is very concerned about escalating Medicaid costs to the state. We've done a really good job in the last few years keeping those down, and we want to continue that. Of this proposal, this is not the first one in Connecticut. There have been 4 or 5 others that have already transferred clinic patients to FQHCs, and it's very possible that others will consider this option in the future to raise revenue. And the state is looking at a serious budget deficit, and we were able to keep from cutting Husky parents this last year, but they're looking at least a $2 billion deficit next year. That'll be another fight. If this CON is approved, uninsured patients would pay significantly higher costs for their care, and I'm glad to hear about the hardship fund, and I'm sure the community looks forward to hearing more about that and hoping that that keeps people whole. But the PCC right now does not charge patients with incomes below 2.5 times the federal poverty level. That's $30,000, the massive sum of $30,000, $350 per year for a single person, and discounted care above that level. In contrast, both FQHCs charge uninsured patients for almost all their care. Even if it's written off, it still serves as a deterrent. People know that, and people of dignity want to pay their bills, and it keeps them from going to get care. There are serious transportation concerns with the proposal. Sergeant Drive is not in a residential neighborhood. Travel from the other 3 clinics by bus during the day, on just a random search I did, ranges from 20 to 45 minutes, including up to 29 minutes of walking in 2 buses. As acknowledged in the application, current patients could shift their care to closer FQHC clinic sites, adding to the wait times there. Yale-New Haven expects to save millions annually, according to the CON application, when this plan is fully implemented, largely by increasing state funding. According to the application, shifting active management to the FQHCs allows for increased reimbursement through the FQHC enhanced Medicaid rate structure. An additional cost to the state beyond the higher rates for services that was not included in Dr. Zawadzki's analysis would be another $1.2 million each year to these 2 FQHCs for enrollment of thousands of new members into their networks in the state's very controversial new PCMH Plus program. These state costs are in addition to the other 5 hospitals that have already shifted their primary care clinics to local FQHCs. These additional costs to the state budget could result in cuts to the Medicaid program or other services. While the addition of behavioral health capacity in the clinic is very helpful, the loss of access to a heavily used pharmacy in the building at St. Rave's and potentially the medication management assistance program that helps people who cannot afford their medications there will cause significant harm. Non-adherence to medication is a massive problem. We are very concerned that many uninsured will not be able to afford their medications. Concerns about abortion services. There's an increase in the plan there's a provision in the plan to increase the number of patients that providers see each day, which really is concerning in terms of quality. People will have less time with their provider. that could affect understanding and compliance with care plans and people coming back. The grant is capped, which could, if costs change and the state's financing is precarious, so that is very uncertain. Any costs above the grant are the responsibility of the FQHCs, as I understand it. If they cannot negotiate a deal, they may leave the venture. Losses could result in reductions to services to all FQHC patients across the city, not just those served in the new facility. The plan also includes bonuses for key CHC management paid by Yale-New Haven of up to $68,665 for each FQHC upon completion of the deal. There are no plans reported to evaluate the impact of the plan. There are also concerns about quality, and I've given you my written testimony, but, and that's actually a lot of the savings are about reducing ED visits and the CHC model. Transferring over 28,000 more patients to the FQHCs in 2015, according to DSS's, the Department of Social Services data. Medicaid clinics performed more poorly than other patient-centered medical homes on 11 of 12 critical measures. The ED visits are much higher for patients in FQHCs, FQHC, federally qualified health centers, community health centers. The patients were significantly more likely to visit an ED than either patients cared for by other patient-centered medical homes, patients attributed to practices that are not certified medical homes, or even the patients that are unattributed with no usual source of care. More specifically, Fairhaven patients had 8% more ED visits per member month than Cornell Scott had 45% more than the state Medicaid average in 2016. This is compared to the entire state average, which includes FQHCs, which is a sizable part of the population. If those were removed, those numbers would go up. And as I said, this is a source of the proposed savings and efficiencies. So in conclusion, we respectfully request that you deny this application. The state budget faces significant deficits, and Connecticut cannot afford to pay for the same care, or less, delivered by the same clinicians that is harder to access. Thank you.
Thank you. Is there any further public comment?
Yes, we'll call Daniel Tobin, Rachel Kogan, Ahmad Maz, and Sarah Jane Bever Critton.
While members of the public are coming up, I just want to remind everybody that if you want to make a public comment and you're concerned about speaking here today, you can still do that by email or mailing us, or you can visit our website. The website for the Office of Health Strategy is portal, that is portal.ct.gov/OHS. So we're going to go ahead and go forward with the next member of the public.
Hi, everybody. I'm Dan Tobin. I have a prepared statement to read into the record. So good afternoon, and thank you for giving me the opportunity to speak with you about the plans to transition adult primary care medicine from Yale-New Haven Hospital to 150 Sergeant Drive under the auspices of the New Haven Primary Care Consortium. The prospect of transforming primary care delivery and medical education in New Haven is very exciting to me, and I appreciate the chance to share with you some of my reflections today. As mentioned, my name is Daniel Tobin. I'm a physician, and I'm the medical director for the adult primary care program at the St. Raphael's campus of Yale-New Haven Hospital. I'm also an associate professor of medicine at Yale University, and I've had the privilege of working in the PCCs, multiple sites, since I began my residency training in 1999. The primary care centers are truly special to me, and their future is very important to me as well. Currently, the Yale-New Haven Hospital Primary Care Centers occupy two locations, one on the York Street campus, the other on the St. Raphael's campus. By combining these two sites into one unified location, our medical providers will be better able to collaborate with each other and provide coordinated, evidence-based, high-quality care to our patients. Additionally, our trainees will benefit from sharing educational resources and working together with the faculty from multiple teaching programs to better learn how to become world-class physicians. We'll also benefit from having one integrated electronic medical record system across the entire NHPCC and Yale-New Haven Hospital, which will enhance our ability to communicate with each other and also with our patients. I'm particularly hopeful about the impact of the proposed embedded behavioral health model. The National Institutes of Mental Health project that 1 in 5 adults will experience mental illness in any given year, and it's essential that our patients have access to meaningful health care services when they need them. By embedding mental health practitioners into the medical practice, both our patients and our trainees will benefit from working side by side with these caregivers. Our patients will have much better access to mental health care and will frequently be able to address their physical and psychiatric care needs in a single office visit. This will reduce fragmentation that we see so much and that often delays treatment or allows patients to simply fall through the cracks. We know that mental health issues can impact physical well-being and vice versa, so enhancing these services will help us care for the whole patient, not just for their body or their mind. Similarly, our students and medical residents will benefit greatly by having daily exposure to experts in behavioral health care, learning how firsthand to use a variety of different treatment modalities to care for common mental health disorders. Poor understanding and access to mental health services is a common barrier in medical education, as well as primary care, and embedded behavioral health should help us overcome these challenges. Finally, the NHPCC offers other very practical benefits for our patients. For example, the availability of free parking, in my opinion, will be a tremendous help. I've witnessed firsthand the anxiety and stress that parking problems cause at our current locations, and I'm very much looking forward to a facility where patients feel that they have safe, accessible parking with no need to leave in the middle of a visit because they have to go feed the meter or they're worried about growing bills from the garage that they're parked in. For these reasons and for many others, I believe that there are significant benefits to this partnership, and I hope you'll support the Certificate of Need application. Thank you again for giving me the opportunity to speak with you today.
Is it okay if the three of us testify together, combining our time?
Yes, just make sure that you state your full names when you do your portion.
Hello, my name is Rachel Kogan, and I'm a third-year law student at Yale Law School. What? Too loud?
If you wouldn't mind moving the microphone
Sure.
a little bit away.
Is this
from you.
better? More? Okay. Hello, my name is Rachel Kogan. I'm a third-year law student at Yale Law School and a member of the Reproductive Rights and Justice Project Legal Clinic. We are testifying today to urge the State Department of Public Health, Office of Health Strategy, and Yale-New Haven Hospital to consider the impact of the planned closure of the primary care center, including the Women's Center, on access to reproductive health care, particularly for low-income New Haven women. As many others have expressed, the new location is much harder to access generally for New Haven residents without a car or ability to drive. Even for those who are able to surmount these transportation barriers, the new location imposes additional hurdles to accessing medically necessary and constitutionally protected care, since the federally qualified health centers, FQHCs, proposed to take on Yale-New Haven's patients are bound by federal abortion restrictions that do not apply to Yale-New Haven. Under Connecticut's Certificate of Need law, the Office of Healthcare Strategy is required to consider whether an applicant has satisfactorily demonstrated that any consolidation resulting from the proposal will not adversely affect accessibility to care. If the state decides to approve the proposed termination, it must ensure that access to all medically necessary care is protected, including abortion. Our concerns are the following. The proposed fix to restrictions on care at Cornell Scott Hill of separating abortion services from other reproductive health care stigmatizes abortion and results in the fragmentation of reproductive health care with negative consequences for the health of patients. Federal restrictions on FQHCs like Cornell Scott Hill would jeopardize access to abortion, even if Yale-New Haven maintains abortion services at its York Street location. Also, given the likelihood of the domestic gag rule going into effect, in order to protect access to abortion, we request that the state require Yale-New Haven condition its block payment to Cornell Scott Hill on the complete physical and financial separation of Title X funds, such that no Title X funds will be spent at Hill's new Sargent Drive location. We will now each provide additional information on these concerns and our suggestions to mitigate the potential harm of Yale-New Haven's closure on reproductive health care access.
Is this good? My name is Ahmed Maz. I am a formerly undocumented and still low-income second-year law student at Yale Law School and a member of Yale Law's Reproductive Rights and Justice Project. Under Yale-New Haven Hospital's proposed plan, the adult medicine and women's center patients will become patients at Cornell Scott Hill Health Center. Cornell Scott Hill is a federally qualified health center, a grantee in the federal Title X Family Planning Program. As Yale-New Haven Hospital noted in its October 8th response to your office's request for more information, federally qualified health centers like Hill are subject to the Hyde Amendment, a federal law restricting the use of federal dollars to pay for abortion services. But Connecticut recognizes that abortion is a medically necessary service, which is why it is covered by our state Medicaid dollars. Under the proposed plan, Yale-New Haven Hospital will facilitate transferring patients to a provider that does not provide all medically necessary care as defined by the state. In response to this issue, Yale-New Haven Hospital states that it will maintain a clinic on its York Street campus after the opening of 150 Sargent Drive in order to continue providing family planning services. While we applaud Yale-New Haven Hospital's continued commitment to provide the services to provide the community it serves with all medically necessary care, it must be noted that segregating these services may nonetheless decrease access. With the clock ticking on their pregnancy, patients who have already gone to the New Haven Primary Care Center site will have no choice but to make another appointment on a later date at a different place. This means already cash-strapped patients will likely incur further loss to their essential income. In addition, providers supported by Title X funding currently cannot take so-called affirmative actions to help patients obtain an abortion. Doctors and staff may not help to schedule or arrange transportation for the procedure. Currently, at Yale-New Haven Hospital, low-income women with positive pregnancy tests have routinely received same-day referrals to abortion counseling services. Currently, at Yale-New Haven Hospital, low-income women with positive pregnancy tests have routinely received same-day referrals to abortion counseling services at Yale Family Planning. This ease of access to care will be lost should the termination of services at Yale-New Haven proceed as proposed. In addition to the logistical barriers to care, segregating this component of comprehensive women's care perpetuates stigma surrounding a woman exercising her right to choose if, how, and when to have children, further jeopardizing access. Yale-New Haven Hospital's decision to terminate its primary care clinic already decreases the amount of community benefits the hospital is providing. Those benefits are a prerequisite to maintaining the hospital's nonprofit status. Worse yet, by impeding financially disadvantaged women seeking to access abortion services, the hospital's community benefits plummet further. With that in mind, the state must ensure that Yale-New Haven Hospital continues to provide the requisite community benefits after terminating its primary care center.
Hi, is this a good distance for the mic? Okay. My name is Sarah Jane Beaver-Critton. I'm also a member of the Yale Law Reproductive Rights and Justice Project. I'd like to talk about how, in addition to the existing restrictions on access to medically necessary care imposed on Cornell Scott Hill via Title X, Title X's restrictions are likely to become sharply more severe in the near future. A new Trump administration proposal to revive what is popularly known as the domestic gag rule would prohibit Title X funding from supporting any referrals for abortion care. Under the new rule, which is almost certain to take effect as proposed, Title X programs may not directly or indirectly facilitate, promote, or encourage abortion in any way. Cornell Scott Hill's providers would be prohibited from helping their patients contact abortion providers, including Yale-New Haven. Under the new proposed rule, even if a patient is adamant in her choice to terminate her pregnancy, the most a provider could do is provide a list of comprehensive health care providers without identifying which facilities on the list provide abortion services. And the doctors would be forbidden from directly referring patients seeking an abortion to an abortion provider. They will be required to provide referrals to prenatal services, even if the patient does not ask for or want these services. If these new restrictions go into effect, Yale-New Haven's commitment to continue to provide abortion services at its main campus is clearly an inadequate solution. In order to ensure that the New Haven community Yale-New Haven serves will continue to have meaningful access to reproductive care, they must also take affirmative steps consistent with their value of patient-centered care to see that patients will truly have that access. This cannot be accomplished if physicians at the new site are gagged from referring patients for the services Yale-New Haven will continue to provide.
As Sarah J. discussed, the proposed Title X funding restrictions pose unacceptable barriers to access to abortion that were previously accessible in one integrated facility at Yale-New Haven's accessible downtown location that does not use Title X funding. If the domestic gag rule goes through and Cornell Scott Hill uses its Title X funds at the new Long Wharf facility, providers at the new facility will no longer be able to refer patients to the York Street Clinic. Additionally, rather than providing non-directive counseling on all of a pregnant patient's options, clinicians would not be required to provide information on abortion, but would be required to refer patients to prenatal services, even if the patient has not asked for them. Gagged healthcare is bad for patients and it's bad for trainees who will be learning in an environment that teaches them to undermine patient choice. Ensuring that the new facility does not use Title X funding would satisfy the domestic gag rule's new requirement that Title X funds be physically and financially separated from any facility that provides abortion as a method of family planning. Planned Parenthood clinics have demonstrated the feasibility of separating funds in order to comply with existing federal regulations. In order to fulfill its pledge to ensure that patients in the community continue to receive comprehensive reproductive health care, Yale-New Haven must commit to a similar model. This would free providers from the gag the federal government seeks to place on medical practice. Patients who assert their constitutional right to an abortion would be able to be referred directly to a provider, rather than misled and shamed with an incomprehensible list of clinics and a referral to prenatal care she does not want. We request that if the state approves the certificate of need, that the approval be conditioned on Yale-New Haven, including a requirement that Cornell Scott Hill not use Title X funds in the new Long Wharf location. This is consistent with Yale-New Haven's mission of excellence in patient care, teaching, and service, and the state's obligation to address the accessibility to care in considering this application. If the deal is to go forward, Yale-New Haven Hospital must do more to ensure the move to Long Wharf will not jeopardize access to necessary and constitutionally protected care. Thank you.
Thank you. Is there any further public comment? 3 more.
Lastly, we'll have Liz Gustafson, Charlotte Kidd, and Douglas Olson.
Thank you. My name is Liz Gustafson, and I am here representing NARAL Pro-Choice Connecticut, located in Hartford. While myself and NARAL Pro-Choice Connecticut are not outright opposed to the proposal to relocate outpatient care to Long Wharf, the intended move coinciding with the Trump administration's proposed changes to Title X restrictions, i.e. the Title X domestic gag rule, raises serious concerns regarding the access to comprehensive reproductive health care. Connecticut has utilized the Title X program to support family planning services, such as through the current grantee Planned Parenthood of Southern New England. Furthermore, Title X funds have been distributed to sub-grantees, including Cornell Scott Hill Health Centers and the Fairhaven Community Health Center, both of which are federally qualified health centers that promote primary and reproductive health care to a significant portion of New Haven's low-income, underinsured, and uninsured patient population. The proposed changes that HHS proposed to Title X that could impact the affiliation you are considering include prohibiting Title X providers offering abortion services, prohibiting Title X providers from referring patients for abortion services, and requiring that Title X providers not include abortion as a part of their pregnancy options counseling. Additionally, physicians employed at organizations receiving Title X funding would no longer be required to provide a referral list of abortion providers to patients who may request one, nor will they be allowed to indicate which providers on any referral list, such as Planned Parenthood, offer abortion services. The new rules mandate that if a Title X funded center continues to provide abortion services, they must maintain 2 entirely separate facilities, which in addition to physical separation, a separate staff, board, separate financial reporting, etc. Finally, eligibility criteria for Title X will likely be expanded to include faith-based organizations that only offer natural family planning as contraception or that focus on abstinence until marriage messages. In effect, these changes will implement a domestic gag rule, barring providers and staff from referring their patients to safe, legal abortion. 93% of all primary care patients in New Haven are served by the Cornell Scott Hill Health Centers. Fairhaven Community Healthcare, and the Yale-New Haven Hospital's primary care clinics, which includes the Yale Women's Center. Family planning patients in communities with high poverty rates are more likely to rely on publicly funded clinics for their healthcare needs. These patients are also less likely to have insurance or Medicaid coverage for their care, relying on the sliding fee scale Title X requires. Neither Cornell, Scott Hills Centers, or Fairhaven Community Healthcare have agreed to forego Title X funding to ensure patients can access comprehensive reproductive health care, which includes counseling and referrals. Although Yale-New Haven has stated their plans to maintain its York Street clinic that provides abortion services, proposed Title X changes will prohibit providers and staff at the new Long Wharf location to provide referral to York Street or organizations such as Planned Parenthood. Furthermore, affirmative actions such as arranging transportation or helping patients schedule appointments will also be barred by those employed at the Long Wharf location, except in the case that a patient's safety is at risk. If implemented, these changes will create significant barriers to the vital services provided to residents of New Haven. Those who are pregnant and who are seeking information about every option available to them will have to navigate the self-referral process alone. Those who are exercising their constitutional right to safe, legal abortion in a state where the provisions of Roe v. Wade have been codified into state law will face significant challenges when seeking health care. With the planned merger between these organizations, I am here to ask the following. How will pregnant patients receive non-directive counseling about all of their pregnancy options, including abortion? And how will they be adequately referred to other local providers for services such as abortion if that is their choice? Thank you very much.
Hello. My name's Claudette Kidd. I live in the community. I'm also a member of Mothers and Others for Justice and Room for All. This is my first meeting attending here, and I'm listening to all that's going on. I attend Cornell Scott Hill Health Center myself as an injury a long time ago made me lose my job, so I don't have access to Blue Cross like I used to, where I had choices. So now my choices are limited. And I look at the healthcare service now, and I feel that it's lost its sense of care. When you go into the medical field, the first thing they're talking about is the care of the patient. Everything is centered around the patient. Empathy, care, the involvement of family and choices, and what they want. And I'm listening to everybody here and what Yale is proposing, and all of it seems to be centered around what they want and not the needs of the patient. And I myself, as a patient, I can say that with all the acronyms that was listed earlier on, and ones that wasn't even remembered for care, care isn't always provided. You're basically chasing your tail, just trying to get a diagnosis of what is going on with you. I myself recently just had an accident, and for the last year trying to get a diagnosis of what's going on with me, and a visit to the emergency room told me what was going on with me, versus my years of going to the health center and just being frustrated with the system of them not telling me what's going on. So if Yale can't even fix the quality of care that's going on in the community, why are you then expanding out to then further open something else? Why are you not fixing the problem that's going on in the community? And if something's working in a community, why are you then not leaving it as it is and expanding somewhere else in a different area? Why are you not involving the community and the people who are in the hospital, who are getting the care and getting their feedback on it to find out what they want versus what you want? It all should be patient-centered care. I'm sure that's what's taught in the medical field, but somewhere along the line that is forgotten. It's all become about a financial profit scheme and not about the patient.
My name is Shafali Pathy. I am the medical director of the Yale-New Haven Hospital Women's Center and, excuse me, and an assistant professor at Yale School of Medicine in the Department of OBGYN. I'm going to read just for being concise. Thank you for this opportunity to speak in the application for the Certificate of Need. I have been at Yale for approximately 10 years, working in the Women's Center as a provider, and over the past 5 years as the medical director. I have always worked in this type of community, both in the Bronx, where I trained and I worked, and now in New Haven. So at the forefront of what my goal is patient care and teaching our trainees the importance of patient care in this community. We have a long-standing collaborative relationship with some of the federally qualified health centers in overlapping patient care, and with Hill Health Center in particular. I think that this collaboration will just deepen that relationship, both for the trainees, but also, more importantly, for the patients. In particular, I believe that under this community health center model, we will improve access for patients, provide more comprehensive care, and give our trainees the valuable exposure to the real world of primary care, especially in these diverse populations where care is really managed by an integrated team. Healthcare is rapidly changing, and our medical education needs to keep up with that. I am convinced that the exposure to this environment will enhance the education of our OBGYN trainees, both deepening their understanding of the needs of the population and really understanding how do we collaborate with our colleagues. I want to focus, I agree with all the others who have spoken on behalf of Yale-New Haven Hospital and the Primary Care Center on the importance of behavioral health and integrated care. However, I want to really re-emphasize Yale-New Haven Hospital's commitment and Yale School of Medicine's commitment to providing and maintaining access to the full spectrum of reproductive health services. I am an OBGYN. I've practiced as a full-service OBGYN, and I stand for what women's health and reproductive health is. I understand that due to the federal restrictions, the federally qualified health centers, and in particular Cornell Scott Hill Health Center, is not able to provide the full array of family planning services that is available to our Women's Center, including services related to pregnancy termination and abortion and counseling of those options. Those services will remain available at the York Street campus and other local locations. Maintaining access to these crucial services is not only important from the patient perspective, but is vital to our training programs. Access to safe abortion and family planning services hinges upon the availability of trained providers and exposure to these services as part of their training. The accreditation, the ACGME, which is the Accreditation Council for Graduate Medical Education, requires that all obstetrics and gynecology residency programs provide training in comprehensive women's reproductive health, and this includes abortion training, in which training is routinely integrated into the residency. Maintaining full access to family planning services at Yale-New Haven Hospital is a key component of our training program, and also of the women's health care in general. Please be assured that the transition to this health service model will not restrict or limit the availability, and we are committed to providing these services for our patients. We hope that the global benefits of this integrated care, which will include reproductive health care to our patients, will be the benefit to the patients as well as to our trainees. I thank you very much for inviting me and including me in this conversation.
Good afternoon. My name is Dr. Douglas Olson. I'm the Vice President of Clinical Affairs at Fairhaven Community Healthcare. Thank you for being here. And it's a privilege to speak to you all today. As a physician, I chose to train at Yale, and I also chose to devote my entire career to community health. I see this collaboration as a very natural marriage of those two career paths. I just want to share a few of the highlights of my own experiences over the past 3 years in discussing this collaboration. First and foremost, almost without exception, I've had the chance to work alongside people who are smart, caring, and kind. Second of all, working at Fairhaven, I've had the chance to work with Yale-New Haven Health System really to start to operationalize and implement the Accountable Healthcare Communities Grant. That's something that we're very proud of, and it's something that all three organizations put in an application to from Center for Medicare and Medicaid Services several years back. The goal of that is to really screen, eventually, all of our patients for social determinants of health and then connect them to community resources when they do screen positive. We have already made great strides in that work, and that will continue. That is a direct outgrowth of this New Haven Primary Care Collaborative, which you've heard about today. We've also worked with Cornell Scott Hill, as well as the health system, on trying to operationalize and achieve shared clinical goals. So collectively known as the quadruple aim, it is to improve quality, decrease cost, improve patient satisfaction, and improve provider satisfaction. And those shared goals have really coalesced around the program you've heard a fair amount about, the Patient-Centered Medical Home Plus program, but also from the Advanced Network point of view, the CSIP program, which is the Community Clinical Integration Program. All of those share the same aims, and working together, we continue to work towards those same goals. I'm not going to talk too much about behavioral health integration because I think it's been done justice already, but I do want you to know that I myself, having served on the Practice Transformation Task Force as part of SIM for the last 5 years, I want you to know that the models that we are proposing for behavioral health integration and primary care integration certainly can take into account all of the work that the Office of Healthcare Strategy via the SIM grant have proposed, and the models we are proposing are both on par with and in many instances ahead of the curve with all of that work that's being done at the state level. Finally, I just want to address cost because I know that's been brought up, and it's not something that we as physicians often talk too much about. But in 2016, there was a paper by a fellow named Robert Nocon in the American Journal of Public Health. And what they showed was that patients who received care in community health centers had overall 24% lower costs than patients who received care in other settings. You should also know that following on the heels of that in 2017, there was analysis out of GW's Geiger-Gibson Institute by a gentleman named Leighton Koo, who really focused on pediatric care and showed that patients who received care in community health centers that were pediatric had a 35% lower cost of care than those who received care in other settings. So that's important given the issues that have been raised so far. The NHPCC model will have care delivered by community health centers that are person-centered medical homes. And I just want to leave you with 3 words that I think certainly define everything we do every day. That's community, and person-centered. Thank you very much for your time and for hearing me speak.
Thank you. Is there any further public comment? No. All right, so we are going to take a break for about 15 minutes, and we will go back on the record at, let's just say 5:45. Thank you, and you can go off the record. Thanks.
Thank you.
All right, is there any further public comment before we go back to questions for the applicant based upon some of the concerns that we heard? All right, no. All right, anything else that you want to tell us, Attorney Wilcox, before we proceed?
You can go ahead with your questions, but then at the end, if there are some other issues that we felt needed to be addressed based on the questions, well, if we could come forward at that time.
Okay, very good.
Thank you.
All right, so we did hear some concerns about outreach to the community about the proposal in general. And so we want to know if there was outreach, if you could just state that for the record and describe what that outreach was.
So it has multiple parts, and actually I'm going to call on Kyle Blue to supplement what I'm about to say to provide some more of the detail from our health system. We have been very active in speaking with our patients as well as with the community. So let me comment first on our patients, and I'll also ask Sue and Mike to join in on that. At the hospital, we have a patient family advisory council for our primary care centers, and so that is one vehicle through which we communicate with our patients in order to get feedback on things that may be of importance, interest, critique, concern, what we do well, what we don't do well. That's the reason for the council. Specifically, when it came to what we're discussing here tonight, and the issue of transportation came up, one of the things we engaged in was having a formal transportation survey among our patients across all 7 of our primary care sites. We wanted the information to be statistically significant for each of the 7 sites, rather than having an averaged result that might not get us to the specifics that we like to understand. So through the great efforts of our team, we ran this survey for several months in order to assure that we had appropriate numbers, enough feedback to feel comfortable in what those results were. And through those conversations with our patients, we were able to get the information we were looking for to better understand what their transportation barriers were, what the needs were, how they traveled to us, what they experienced, etc. So the planning around transportation was fully informed by our patients and their feedback. As one example, we also have a communications team where we have patient representation. So those are among a few of the things that we have been doing in order to assure that we're getting the voice of our patients in what we've been planning. And I just want to see if Sue or Mike have anything to add before we start talking about community communication.
Sure. So for us, it's been mainly communicating with our staff regularly about how this is playing out, and that's been going on for now several years. We also have several patient advisory groups. We have one as part of the PCMH Plus, the Patient-Centered Medical Home Plus initiative, also one for our HIV Ryan White program. And while they are made aware of this, I mean, quite honestly, this is really more to make it clear that although they may hear of this out in the media, that this is not going to impact. We are still going to be at $374 grand. We're still going to be at $50 grand. We're still going to be at East Haven. I think obviously the communication to patients is more on the Yale-New Haven Hospital end, because they are the ones who will be most impacted.
So our efforts have been similar to what Dr. Lagarde articulated. In fact, Suzanne and I did a radio show together. Suzanne and I did a radio show together earlier, maybe a month or two or so? Soon?
Probably a year ago.
Yeah, time flies when you're having fun. So there have been extraordinary efforts to communicate both to our staff and to the community what this is about. Quite honestly, there was grave concern on our parts that people would perceive this as Yale-New Haven Hospital absorbing the health centers. That is a notion that we wanted to squelch quite quickly and definitively. And so we've held a series of town hall meetings across our 20 care sites. It is a common topic of conversation during our monthly management meetings, where we not only disseminate information, but we receive feedback from our staff members who are members of the community, and they get approached when they go to church or when they go to the supermarket. So we have that means of communication as well. And I would add that one of our staff members, or a couple of our staff members, also participate on the communications committee that Cynthia spoke to, and so they have been actively attending and interacting in community management team meetings.
Good afternoon. My name is Kyle Ballou, and I'm Vice President of Community and Government Relations at Yale-New Haven Health System. As Mike mentioned, we also have people on our staff who are out in the community on a regular basis. The way New Haven kind of generates information within their communities, they have community management teams. And those are actually divided into neighborhood community management teams. The majority of affected community areas are the Hill North, Hill South, Whaley, Edgewood, Beaver Hills, Dwight, and West River. I have someone on my staff who goes out to those meetings on a monthly basis, so every one of those meets on a monthly basis. He continues to update the community on this consortium, as well as Mike has someone on his staff who also goes out to those same meetings, so it's almost a tag team. And they're out there regularly. As late as this morning, there was another communication with one of the community management teams.
So would it be your opinion that the average patient who goes to Yale for services would know that there's going to be this that they would know that they would need to then go to the federally qualified health centers following the, too close? If this application were to be approved? Closer. Did you understand my question? Should I think, okay.
I think I understand your question.
We want to know if patients as a whole are knowledgeable that this change is impending if we were to grant this proposal.
So I think I can speak to the community side like I've just spoken to, but I also believe that our providers have been speaking to their patients, and these are the patients that are affected. So
Yes, yes, thank you, Kyle. I'll ask Dr. Hewitt to comment. I'd also like to ask another member of our team who was here, who was involved in the surveying of our patients, because in order to talk about transportation, we had to talk about exactly what was being planned for, and therefore that was very much a critical component of gaining the information that we did. So let's start with Dr. Hewitt.
So I had a couple of comments. One is that communication is ongoing, so it's not just what we have done, it's what we fully intend to do. And as we've mentioned, our hopeful go-live date is September of 2019. We are, in my opinion, the way I've shared this thinking with my colleagues, is I view us as moving past this technical part of how do we make the NHPCC happen, and now into operations. And I discussed this yesterday morning at our town hall at Yale-New Haven, where this is where we need to have closer team-based collaborations, patients, providers, and all of us in the same room, and really talking about how do we move this out. As a physician in practice, you can never tell someone the same thing too often. It takes a while for the message to sink in and to really hear what their concerns are. And all of us on the front line are going to have an ongoing need to do that right up until and through the move, I'm sure.
If one other person is going to weigh in.
Thank you. I don't want to get too close. Good evening. I'm Rebecca McCrae, and I'm Director of Ambulatory Operations for Yale-New Haven Hospital, and I'm a nurse. My role recently, over the summer, as Cynthia mentioned, was to be the team leader for the transportation survey. So as everyone's mentioned, we conducted the survey with our patients at all of the sites, and we conducted it this past summer, and we asked questions of our patients. How do you get to our clinics? How do you plan to get home from our clinics? What neighborhood do you live in? As Kyle mentioned, we asked that question. We also finally asked the question that people have been talking about. A benefit of this is, have you ever missed an appointment coming to our primary care center because of things such as a bus cost, parking, or a gas cost? And we also asked other. So in administering this survey, our team members did speak to patients about we're concerned and interested about how you get here and what your travel situation is. So we did, as Cynthia mentioned, we do have an active patient and family advisory council where we discuss challenges and opportunities of what we can do with our clinics. And as Dr. Hewitt mentioned, we have our communications committee, and we're in the process now of waiting to hear exactly what's going to be granted to us, and we have a full communications plan that we will be executing. And again, as Steve said, when you have patients and you interact with their families, it's an ongoing process, and when we're asked questions, we give the best answers that we can. So thank you.
So the other question that is with regard to outreach would be about the access to family planning services. And so our question would go to Yale. How are you communicating how that would change if this proposal was granted to you?
So let me go back to your first question, and it relates to the answer to the second as well. And I think maybe we've been remiss in not addressing this more specifically. We are still, and should we have the approval, we are still 10 months away from operationalizing this change. And we have many things that we have, if you will, locked down. But there are still very important details that will be important to our patients, such as how do I schedule my next appointment once this change occurs? Things like that. I mean, very specific things. It's the reason why we developed a communications committee, so that everything will be crafted with the appropriate language, at the appropriate levels, the appropriate translations, etc. And then not just having written materials, but also oral communications with our patients. That is still the work that is in front of us. So some of the specifics around not what we're doing, but how we communicate it is the work that we still have in front of us. We're committed to doing it. We have the structure. It involves all three of our organizations with, as Mike mentioned, representation from each. We also have patients on that committee, so that all of this can be operationalized in a way that will assure that we're effective and get feedback, et cetera, much like what Rebecca described with the transportation survey. So I just wanted to caution that some of what we're talking about here tonight, some of those very specific details need to be worked out in a way that assures that as we get closer, we have those specifics included in the communication. Just to illustrate the point, yesterday morning we had our latest update meeting with our Yale-New Haven hospital staff, as well as our physicians. And then we do a regular town hall about this work and what we're doing. We've had numerous, and the latest one just happened to be yesterday morning. And we even say to our own staff, here's everything that's been completed in the planning. Here are still some details that we are working on that have not yet been completed. So it would be the same for our patients as well. I hope that at least puts some context around what we're ready to talk about and what we still have in the way of work to do. Specifically to the family planning, as we said earlier, we are committed to continue to provide those services, so that remains unaffected by what we're talking about here tonight in terms of the formation of the consortium. We also heard from some of the speakers tonight that there is great concern about what is referred to commonly as the gag rule and what that might mean in the way of change. So we know what we operate today, and I would ask in a moment for Mike Taylor to comment on this, but certainly we are committed to assuring, as we do today in working with Cornell Scott Hill Health as well as with Fairhaven, that our services are available to patients both of the hospital as well as of their organizations. But it's a little bit difficult to speak specifically to what we would do with a rule that has not yet been promulgated, and therefore we don't know what we would need to be responding to. What we will say here tonight is that we're committed to work together, and I'd like Mike to comment on how we would proceed.
And since we, the Cornell Scott Hill Health Center, are indeed the Title X grantee, what we would commit to in this forum, not knowing what laws or regulations might be promulgated and applied to that source of funding, is a way of continuing access for patients.
So one of our concerns is once we close this record, we have only a few months to issue a decision. So without the details, it's hard for us to analyze whether your patients will still have access to the services that they need. I think that the question that we want the answer to is, when will you have details about, for example, your transportation plan and also the hardship waiver, because those are things that are concerning with regard to the application.
I think probably the best thing to do would be for us to gather that projection and document that and provide it to you in the subsequent, where's Jennifer? Follow-up to this. I think it isn't hard for us, given the work we've already done, to make a specific projection on having that transportation plan in terms of when those details would be worked through. I think that the issue on the family planning is, again, to be crystal clear here tonight, that we will continue to operate these services. There is no ambiguity around that. So again, the issue of how we can provide you details and plan for any change that may come from the federal government is a tougher one for us to respond to. Maybe you can help us with that one.
Attorney Wilcox, I saw you.
Oh, I was just going to suggest that perhaps as a late file, we could provide something about our timing in terms of what we anticipate, what we can project for developing our transportation plan, and making decisions around the hardship fund we discussed.
Right. Those two we would certainly could provide.
So you're saying just in terms of timing as to when those would be available, or would we receive any substantive information about those plans?
Well, I think late file, something we could file very quickly after the close of the hearing would be, okay, here's our plan for getting to a plan, and here's what we think the time that will be needed. And then we could certainly commit to providing those or providing more details once we had reached those timeframes.
All right, just one other question, and this is for Yale. I think that the question that I wanted to ask is, have you thought about how you would communicate to patients in terms of family planning, the change if it were to go into, if the new law were to go into effect, that would create some barriers for the the FQHCs to perform referrals for certain services. Do you know what I mean?
So I think Dr. Pathy really did a very good job of explaining the commitment for all the reasons that she outlined. I thought she did an outstanding job with that. And so what we can say here tonight is we're going to live by that. The problem in how we would communicate something that hasn't been promulgated yet is a difficulty. And so I wouldn't want to leave here tonight with an expectation, like with the transport plan, for example. We know we need a plan. We know we can project how we would get there. We've already done a lot of work, and we would flesh out additional detail as Jennifer just commented. With this one, it's a much tougher one beyond the absolute commitment to continue to provide the services, and that as she spoke to, the fact that there is a deep commitment both for the sake of our patients as well as our trainees. It's actually a requirement of ACOG, the American College of Obstetrics and Gynecology, that this be part of the training. So these are things, and one of the things that we committed within our own organization to the Yale School of Medicine is that this opportunity, which Dr. Hewitt spoke to earlier, will only enhance training. It will in no way endanger the status of our training programs. I mean, that's one of the core elements going into this for us. So I hope you can appreciate that this is an issue that cuts across many dimensions for us, and is therefore something that we are completely committed to assuring that we don't stumble on.
Right. From our point of view, I think we understand that you still will be offering the services. I think the concern is whether or not, I think we're concerned about how that would be communicated to patients in terms of how they can actually access those services in a timely fashion. I think that's the concern.
Well, I think offering them is one thing, being effective in how we offer them is something else. If we're not effective in getting that information to our patients, then we will have underutilized services. So either way you look at this, we have to be effective in assuring that women know that they can get these services from us and that we are continuing to provide them. Exactly how we do it under current circumstances versus future change circumstances is the tough thing for us to address until we understand what those changes might be, if in fact they come to pass.
Let me just...
I don't know if anyone else on the team would like to add to that.
I have one question in regards to the analysis done by the Department of Social Services reflecting any savings in the state Medicaid program. Is there a way we can get an updated analysis to include that patient-centered medical home costs?
It's in there. I think that was also in Dr. Zavosky's note, that if that were to happen, if the PCMH, the patient-centered medical home glide, were to occur, I think you need to clarify there are two types of patient-centered medical homes, right? Okay. So the Yale Primary Care Centers recently achieved patient-centered medical home accreditation. And in the state of Connecticut, that means they will be eligible today, not tomorrow, but today, to get an additional incremental reimbursement for their services. That piece was taken into account in Dr. Zavosky's analysis. Mm-hmm. What was not, to my knowledge anyway, taken into account was the PCMH Plus, Patient-Centered Medical Home Plus program, completely different. And I don't think that was taken, that wasn't mentioned, that I saw.
So I just second exactly what was just told. Is in the analysis, there's actually a breakout of the two different components with and without PCMH, but not the PCMH Plus. So Yale-New Haven Health System currently today does not have the PCMH Plus. What we would do hypothetically in the future is a hypothetical. So I think to that extent, it's included.
I think we're stating that while now Yale-New Health is PCMH designated, that is a prerequisite to apply for the DSS PCMH Plus program. And I want to be very specific about that. An entity can apply once you meet the PCMH criteria, but that does not necessarily mean your application will be funded. That's a DSS decision.
I just wanted to add a comment to the prior about the communication. So having been a physician whose practice has changed a couple times, we haven't been at the same Rayfield campus forever. There are many ways that we directly communicate with patients when that happens, and as a physician, we're actually required to be sure they know where they can go for care, who they're going to see, how they will access that care. We will fortunately be on the same electronic health record, so accessing their documentation through Epic will not be an issue for us to accomplish. And I think that was one of the concerns that the first woman, whose name I don't recall, brought up this afternoon, which was worried that her physician may change and she may not know who she's going to see, or she may not be able to access us through Epic. And I really appreciated her coming forward to share that. And I know she had to leave because she had childcare, I think, but I just wanted to find a way, and perhaps the minutes could reflect that her doctors are not leaving. We are going to 150 Sergeant Drive. We will continue to be her doctor. Our nursing staff is not leaving. Our nursing staff is coming with us to 150 Sergeant Drive. It is critical to all of us who work in the primary care centers that we have our team who comes with us for our patients. They're part of our team. So we move lock, stock, and barrel. We're on my chart, as she noted. We will continue to be on my chart at the new site.
Planning on asking any questions, but to clarify the PCMH Plus question, I think the question is, can the applicant work with Fairhaven to come up with a projection with DSS on what the cost would be to include the PCMH Plus payment that's in addition to the PCMH payment for projected attributable lives? You know, it sounds a little complicated, but there'll be a certain number of people who will be going to Fairhaven if this transaction goes through that are currently probably not going to Fairhaven. Fairhaven is a participant. There's a participation in the PCMH Plus program that involves an add-on payment for PCMH and then another payment that's given to the PCMH Plus participating entities to participate in that program to provide care coordination. And so that's the piece that seems to be missing from the analysis that we would ask the parties to work with the SS to come up with a projection on.
Chime in on that one. So, as you know, both Cornell Scott and Fairhaven are participants. It is a $4.50 per member per month add-on. But the presumption in the plan is that with the additional funds, we are able to provide additional services, care coordination, nutrition, pharmacy, and that at the end of the day, there will be savings. So it's going to be, I think, hard to calculate that net. Obviously, if the Yale PCC clinics come over to the two FQHCs, the glide path is history, because that doesn't apply to FQHCs. So we're really just looking at the differential in costs for the FQHCs at their what we call their PPS, or the prospective payment system rate. $4.50, yes, they would, I believe, they would become our patients and they would be eligible for that per member per month. But I don't know how anybody's going to calculate what the shared savings. We believe there's going to be significant shared savings for all the reasons we've elaborated in terms of the shared EMR, use of certain e-consult, telehealth type of modalities, etc. I think, as you know, this coming Friday, the DSS is going to announce the results of shared savings for the first year, but I would also caution this group to take that with a grain of salt, only because it takes time to build up momentum to getting to significant shared savings. So whatever they show, I think the belief is, certainly I believe, and most people believe, that those shared savings will only increase over time.
I believe, to follow up with clarification, I think we can take notice that that is a gross estimate. If the PCMH Plus payment is included, that is not a net projection, but just a gross projection of what the initial cost would be.
So to clarify, though, in terms of, was that sufficient for you, just to understand the $4.50 per month? Okay.
Does the applicant have anything else that they want to address? I understand that there were some concerns raised by the public that you wanted to talk about?
So I just want to make one more point regarding the PCMH Plus per member per month payment. It is DSS that has the patient attribution criteria for determining which Husky patients PCMH Plus dollars are paid on behalf of. All of the details of that attribution methodology are not necessarily shared with us as provider entities. So you might be better getting that estimate from DSS since they have all of the information. We can guess, but I don't know how accurate a guess it could be.
My suggestion would be that, I don't know, Attorney Wilcox, would you contact DSS to find out whether or not they can provide that information?
Well, I'm sorry, I thought we just addressed it a few moments ago.
Yeah. Let me just double check. So, are you?
Yes, we understand. I think just to be clear, we understand that the net, any savings or shared savings, this is a little complicated, PCMH Plus, but shared savings that may be distributed are in year one, and there may be an additional net savings year 2, year 3, depending on how long the program goes. I think we were just looking to answer the concern that was raised, to have sort of just a gross projection of what the initial cost would be if additional lives were attributed. So it is, in fairness, a request that probably needs to get to DSS in some way. So.
Appreciate that, thank you.
In answer to your other question, there was one other item that had come up during the commentary that I want to make sure that we did address while we're here tonight. So one of the speakers referred to the Yale-New Haven Hospital paying a bonus to the management of the 2 health centers, and I think we want to walk our way through that one because there was something I think that was that needs clarification here. There is nothing in the construct of the community benefit grants that we are committing to pay to the respective organizations that relates to management bonuses for anyone at either of the health center organizations. So want to get that on the record. There is an element in the startup that does relate to the person who raised the concern that we do want to comment on, and I'm going to ask my 2 colleagues to speak to that.
So I'll start on that one because I take 100% ownership of this. As we mentioned early on, we've been at this for nearly 4 years, and I can speak from the perspective of Fairhaven that I've had several of my management team who have worked above and beyond the call of duty. They have their day jobs, and then they have this job, which there are meetings at night, there are meetings, there are calls. And so I asked of Yale-New Haven Hospital if in this context of what we call pre-transition costs, whether they would be willing to give a small bonus to 4 of my management team in reflection of really what has been above and beyond hard work. I want to make it very clearly known that I is probably the main decision maker at Fairhaven. I'm not receiving a single penny from this. This was really my ask for my team who worked really, really hard, and I was very grateful that Yale was willing to accommodate that.
I echo what Sue shared. We have already communicated internally that I, as an individual, will not participate in the distribution of those funds. I'm very pleased and grateful that Yale saw fit to acknowledge the extraordinary amount of effort that people on our management team have put forth to bring us this far. We sometimes jokingly and say internally that we ought to have tents and cots at Yale-New Haven Hospital to accommodate the number of meetings that we've had to participate in to get this far. So the funds are intended as an acknowledgement of what Sue said is the efforts of people that are really way beyond and beyond the jobs that they now hold.
Anything additional, Attorney Wilcox?
That's the only issue that was raised during the public comment portion that I wanted to be sure you got additional information on.
Okay, so we did discuss the possibility of some late files with regard to the hardship waiver and transportation. So we're looking for as much detail that you can give us with regard to plans for that.
When would you like that?
I would say 2 weeks.
We will provide that as a late file, and it will have the degree of detail that we've been able to work out by that point, but also a projection of a timing for when we think we'll have it finalized.
Okay, so we'll leave the record open for those documents. Is there anything else additional, Attorney Wilcox?
Yeah, I think we've all gone into a lot of detail, and I just wanted to thank you all for your time and your attention and being here and withstanding some of the sirens and the alarms we've heard, but we really appreciate your courtesy and the careful attention you've paid to this proposal.
Anything else additional from us at OHS? No. Okay, so thank you all for attending today. The hearing is adjourned. The record will remain open for 2 weeks from today's date for receipt of the late files from the applicant. Thank you.
Thank you. Thank you.